I have a question for Sandro. Thank you very much for your talk. I'm thinking about the pre-habilitation NTMS that you talked about and how it might boost performance of patients before surgery. So you might increase your language mapping results. But I wonder to what extent this might change the extent of resection. So you might be able to remove less tumor, and then patients might be more impaired after surgery. So what do you think about that?
You mean if it could happen that it goes the other way around?
Yeah.
Sure. Could be risk, yeah. It's something you need to talk to the patient to, but I mean, if you have like a small tumor remnant in which you know there was language in it, you can't make it worse, so you need such a case maybe. But that's also, yeah, sorry, that's also a problem why I wanted to do such studies also maybe in healthy volunteers, even people who wanted to do it, to test such protocols, but the ethics committee, which is usually not a problem in my institution, didn't want me to do it. So.
I have a question for Sebastian. I didn't understand very well. Did you use Thank you. In non-German speaking people, did you use a neurolinguist and a neuropsychologist, or new neurologist and at all?
In the German speaking patients, so our standard program is with a neuropsychologist who has lingual experience. That's our standard program, but when we operate on, for example, Russian patients, so our neuropsychologist, who's usually there during the awake craniotomies, doesn't speak Russian, and therefore we took residents who were bilingual or someone from the staff just to translate the awake during the awake craniotomy. But our standard program is using a neuropsychologist with a linguistic experience.
But we had several patients, non-Dutch speaking in Flanders, and we used an interpreter in combination with a neurolinguist, and it fits very well.
Okay. Okay.
Yes, go ahead. Maybe, yep. Yeah, but yeah. So maybe I can comment on that. So yes, in some cases we also had a translator with our neuropsychologist, but it didn't really work, at least in our institution, quite well. So the main focus of the study was, does it work if you have a language barrier between your patient and your neuropsychologist? Because we don't only have patients who come as private patients from another country, we also have a lot of people who live in our city who don't speak German or a language which we can analyze that well in the OR. That was like the main objective of the study. And it turned out that's not that good.
Sorry. Yeah. So isn't it different? I mean, there is a big team in Moscow, for example, but there are many teams everywhere. To fly in someone from another country for a day, I mean, it's a couple of €100, nothing compared to the rest. And you have someone who is an expert in language testing in the patient's own language. Just an idea.
Actually,
we do it with our students, by the way. We have an international student program, and if we have a Greek patient, well, and we have a Greek student, they go in and do the testing.
Yeah, we did the same. I mean, we have sometimes some people who know the language quite well and also trained linguistically. But it's not that common that you find proper trained people. These were Swedish, Finnish, Arabian, Russian, Romanian, Azerbaijan, And the problem is as well, if you operate a patient who is from Azerbaijan in Russian, which he speaks since like 2nd grade, and you don't monitor Azerbaijan, it happened that he is not able to speak it anymore, probably. He speaks Russian perfectly, but that's not what he wanted. So.
Could it depend on the testing that you use? On the assessment that you use intraoperatively? Because I mean, a lot of assessments that you use are specifically made for that language, whereas if you use an interpreter, you probably, I assume that you interpret as well.
No, mostly we use action naming and object naming,
right.
Mostly. So this is, and we adapt the vocabulary, of course, so it shouldn't be the problem.
Could still make a difference, I think.
Yeah. Yes, but that's something no one actually really looked at in a surgical way. So this turned out to be much worse than I knew it might be not as good, but it turned out to be much worse. So that's why also we presented to find solutions, because I think we are not the only ones who have these patients, right? So.
Question to Emma, please, about the executive function. So 2 questions, actually. One is what kind of task do you use for the executive function? And the second is that you mentioned that it was location independent. So which regions, which locations of tumors did you have for the executive function impairment?
Thank you for your question. We used a Stroop and Stroop inhibition test for executive functioning and made a compound also with TMTB and to see look at the flexibility with lexical fluency and the SOMAR flexibility tests. And we looked if one of these tests was disturbed, we considered the domain as affected. If it was below the different thresholds. And the second question, we scored all the different MRI variables on different locations and took left, so all the different lobes, frontal, occipital, temporal, and also looked at hippocampal involvement, insula involvement. Did it on T2 flare and T1 with gadolinium, but yeah, that's special for the high-grade gliomas. And yeah, we correlated that to all the different domains and see if they were correlated. And of course, for language, we found correlations, but for executive functioning, none of all these variables had significant correlation with our outcome measure, executive functioning. Thank you.
I have a question regarding the intraoperative test of writing. So how do you perform it practically? How do the patients write during the surgery? And if you are able to distinguish the writing errors related to language to the motor ones, because it's not always so easy, the patient writing, what is the difference between both? And if you are able to define.
Thank you. That's both very good questions. So first, the practical part. It is not the most easy task to implement in awake surgery, that's for sure, but it is feasible. We've done it with a couple of patients, and there's more centers doing it actually. So as soon as the only sort of really constraint, or the only thing that really needs to be done during surgery is that the right hand, in right-handed patients, is free to move. So we make sure that there's no electrodes or things that are like monitoring other kinds of things on the right hand, so that they can actually use the hand freely. And then we position the screen or the piece of paper that they have to write on in the most comfortable position for them, so that they can actually see what they're writing, because the feedback is of course important in the process of writing. And although it's not like I say, that they should be comfortable. It's not as comfortable as looking at the screen passively, of course, so we don't also, that's also a reason why we don't want to assess too many items, for example. But for a short period, it's definitely feasible. And secondly, the question about how to distinguish between linguistics errors and motor errors. There's two different ways in which we try to control for that. First of all, we have writing samples of these patients before surgery, so we can compare with these, and we study them before surgery so that we can take the decisions on the spot during surgery to see if it's normal or not. Then, of course, because they are in a different position than how we test them before surgery, it's still possible that the handwriting, quite often actually the case, that the handwriting looks very different. And then we try to compare it with the other words that are written in the same intraoperative session. There's some cases, of course, that it's not clear, and then it's difficult to take a decision on that, and you don't want to risk taking too risky decisions on that either. But there are quite a lot of cases where you get actually clear misspellings, and these are the ones that we can actually judge. The more peripheral aspects of writing, so how well shaped the letters are, these are things that we don't consider during surgery because these are very difficult to judge.
Dr. Krieg, I was intrigued by your one of your first slides where you showed the TMS that basically predicts deficits that you, if I understand, didn't find at operation or during a surgery, the IOM, or am I wrong? What happened actually during surgery? Did you remove the cortex and so that there was deficit happening, or was it afterwards that the deficits happened, or is it when you went down in the white matter tracks that you saw the deficits? What's the difference between the fact of not finding something during the surgery, the IOM, getting a deficit, and getting it with TMS? When does the deficit happen, actually?
We did, I mean, this study we did then, you mean the one in which we resected TMS points? I mean, this was a retrospective analysis of the patients because this question came up over time, and we now, or even like 2 years after we set up the program, we haven't had any of these cases because everyone knew how to deal with the data. But since no one knew, and we had this new setup, no one knew how to think about these points. So I can't tell you what happened in the surgery. That's also limitation, but we still found, actually, the main objective of the study was that I wanted to have good data to take out some of these very, very frontal regions, because we have a lab which investigates like fresh slices to investigate what happens with these points, which might have been MEP negative and then turn out to be MEP positive. So this was actually the other way around, that I wanted to show that they don't have any deficit. And it turned out that they got some. So.
Thank you. I have a question about NTMS, preoperative NTMS. Do you have an idea of how long it would take to get a functional reorganization in order to be able to operate the patient? And how frequently should we apply NTMS? How many sessions and how long it would take in an oncological perspective? Just to have an idea if it's very long or if it can be quick. Thank you.
So you mean therapeutically? How long it takes if you do a therapy, let's say you want to change network and you put on repetitive RTMS?
Yes.
There's just one report, and they did it like 12 days, every day for 10 minutes, which is quite a lot of stimulation. So, and it's within the limits of the safety margins. So that's what I would do, like 12 to 14 days each day, like 1,200 stimulations.
Okay. Thanks.
I have a question for Manuel Carreiras. You showed us correlations between alpha waves and language that were moderate, so around 50%, 38%. If you would R-square those values, you'd get maybe 25% of the variance explained. So my question is, how do you explain the 75 remaining? What is it? And how useful is that to understand cognition in individuals instead of groups?
Okay, well, I think is interesting is looking at the future to see whether at the end of the day you are able to classify whether this guy is going to have a very good prognosis or, recovery or not. So this is one of the aims that we will pursue in the next months. The other thing is that, to me, it was remarkable to see the correlation because, it's not easy to find a correlation between functional and structural and also a correlation with the behavior. So that means that the guy is improving, and this improvement probably is based, and I say probably, because it's a correlation, it's not a causation, so we don't have the grounds to predict that it's a cause. But, there is a nice correlation between the structure and function and between brain and behavior that I think is very promising. So as I said, this is only 8 patients, preliminary data. So, I'll tell you a little bit more next time.
I would like to ask a question to any of you. As a piece of brain is resected due to a tumor, and other areas of the brain take up that function and become functionally active, have you observed in the follow-up MRI scans anatomical changes of those areas?
Okay. I need to remember. So, what you clearly find is differences in some anatomical changes, for instance, in white matter.
Of gray matter or white matter or something like that.
Well, with gray matter, I couldn't tell you now, but with white matter, we saw differences, yes, between pre and post. And so it's quite likely, but I don't know, I can't remember now whether there is differences in T1, probably not. But in DTI, you observe differences. And, sometimes when you see that there is a disconnection between these 2 regions, then there is a kind of neurodegeneration of fibers that you are able to observe in after surgery, yeah?
Yeah, but new circuitry will be created. Are you able to detect that new circuitry?
Well, it's hard to see how is the new circuit created. You see differences between the pre and post, and then you assume, because, one of the things that we need to realize is that what fMRI, in this case, DTI is telling us is a kind of lie. You need to make a lot of assumptions in DTI, and depends also on the measure that because there are different types of measures that you can use to see these differences. So one thing is what this virtual reality is telling us, and then what you guys, when you get and operate, see the real brain. So, but it's important that there are commonalities, but it's important also to be careful and interpret those data with care.
Okay, thanks. Well, if there is no more questions, we will give for finish this session. Thank you very much to all of you.
Well, I understand how it's actually related with